Hello and welcome to our session on challenges in transfusion medicine, the way forward. Welcome to HemeCon 2022. And as we begin our next session, I will introduce the chair and the co-chair of our session. The chair of our session is Major General Saleem Ahmed Khan. He's a senior professor of hematology and a renowned professor. An academician. He's a supervisor and examiner of FCPS, MPhil, PhD in hematology. He has trained and mentored a number of hematologists in the country. He's a commandant of Armed Forces Institute of Transfusion in Rawalpindi and a principal of Army Medical College. He's a regular presenter in many conferences. He's a dean of faculty of hematology in CPSP, as well as a pro vice chancellor of National University of Medical Sciences, Islamabad. As we move on to our co-chair is Dr. Farhat Abbas Bhatti. He is an FCPS. He did his FCPS in 1991. Later, he had his on-job training in transfusion medicine from UK, and he worked as a commandant of Armed Forces Institute of Transfusion from 2012 to 2015. He is currently working as a head of Department of Pathology and consultant hematologist at High Tech Institute of Medical Sciences, Texila. Okay, and then the panelists. We have three panelists. I'll start with Dr. Hassan Abbas Zaheer. Dr. Hassan Abbas Zaheer is a renowned person in blood transfusion. When we talk about blood transfusion services and national reforms in Pakistan, he was previously a national coordinator of Safe Blood Transfusion Program in Pakistan, and currently he's a WHO advisor on blood regulation, availability, and safety. Uh, he's representing Pakistan in WHO. Then we have another panelist. Her name is Dr. Ali Soomro. She's head of blood bank in National Institute of Cardiovascular Diseases. And our third panelist is Dr. Uzma Chauhan. Dr. Uzma Chauhan is the head of Regional Blood Center Bhavalpur. And she has a total experience of 2 to 3 years in blood transfusion services. Moving on to our first speaker, and honestly, I'm very delighted to introduce him because Dr. Magdy ekiaby, he is the head of blood transfusion center and hemophilia treatment center in Shabra Vishi Hospital in Cairo, Egypt, in Giza. Dr. Magdy has served as a member of Egypt's National Blood Transfusion Board, and he is also a member of Ministry of Health and Population since 1986. He is also responsible for Arab Transfusion Medicine Forum. He has served the hemophilia community in Egypt since 1998, both through his profession as a hematologist and blood transfusion specialist. He is a member of the board and vice president of Egyptian Society of Hemophilia. He's currently the head of blood transfusion and International Hemophilia Center, Shab Ravishi Hospital, a position held since 1983. He has received the World Federation of Hemophilia Ingra Mary Nielsen Award for Scientific Research Achievements, and he was also awarded the Lifetime Achievement Award from Arab Transfusion Medicine Forum in Cairo. Today, he'll be speaking on mini pool plasma fractionation as an option for optimizing utilization of domestic plasma. Thank you so much for joining us, Dr. Magdy. Let's hear this session. Thank you.
I would like to thank very much Dr. Bushra Muiz and Dr. Shabneez Hussain for inviting me to talk to the Hemo Conference 2022, which is the 24th Pakistani Society of Hematology Annual Conference. My topic will be on the improvement of the utilization of domestic plasma through a new technology called mini pool plasma fractionation as an option for optimization of the utilization of domestic plasma. So these are my declarations of interest. So normally, as we all know, that the plasma can be prepared from whole blood, in a case of which we call it recovered plasma, or can be directly collected by apheresis from the donor, which we call it source plasma. And actually, the evidence-based practice guidelines for plasma transfusion is limited. It is mainly indicated in cases of massive transfusion in patients with warfarin therapy related intracranial hemorrhage, in replacement of coagulation factors in the absence of factor concentrates, and in therapeutic plasma exchange in cases of thrombotic thrombocytopenic purpure. In the meantime, we have adverse events due to the fresh frozen plasma transfusion, which includes transfusion-related acute lung injury, transfusion-associated circulatory overload, allergic and or anaphylactic reaction, and other less common risks, which include transmission of infections, febrile non-hemolytic transfusion reactions, red blood cell alloimmunization, and hemolytic transfusion reactions. In the meantime, the surplus plasma in our region, in the East Mediterranean region, we can see that in order to qualify this plasma for fractionation, this plasma has to come from regular repeat donors. A case which we see that this only happens in 30% of our donor population. So 70% of the plasma will not be able to be qualified for plasma fractionation. And consequently, this will lead to a lot of waste of the plasma due to the limited clinical indications, and in the meantime, the inability to qualify this plasma into fractionation. And paradoxically, we have a problem in access to plasma-derived medicinal products in our region, in East Mediterranean region, as is the case in most of the low middle income countries. So if we look into the World Federation of Hemophilia Annual Global Survey in 2020 about the availability or the use of factor VIII in the different regions of the world, we will find that about 35% of the population residing in the Americas, Europe, and Western Pacific are almost consuming more than 85% of the factor VIII. And that the rest of the world, which is about 65%, have only access to less than 15% of the factor VIII. A situation that shows a great inequality on the access of these important products to our patients with inherited bleeding disorders in our regions. Likewise, the situation is the same for the intravenous immunoglobulin. We found that the main consumers reside in North America, in Europe, in Asia Pacific, and in our regions, Middle East, East Mediterranean region, and Africa. The access is extremely limited. And the situation will aggravate with the increased demand on the IVIG in the developed countries, and in the meantime, with the situation where the plasma collection was relatively affected during the COVID pandemic, a situation that will show a crisis in the next 1 or 2 years in the access to these important medicinal products. So with this, there has to be a solution that will help us as developing countries to better utilize our domestic plasma, and in the meantime to use this approach to fill in the gap in the access to the plasma-derived medicinal products. And this comes in the form of a technology called mini-pool plasma fractionation to enable national blood establishments to produce safe plasma, coagulation factors, and immunoglobulins. So the rationale is to improve the utilization of wasted FFP through local manufacture in a mini pool fractionation validated sterile medical devices to produce coagulation factors and immunoglobulins, which might help to fill in some of the gaps in the supply. So how this solution works? From the fresh frozen plasma, we separate, as usual in the blood banks, the cryoprecipitate and the cryopool plasma. The cryoprecipitate, when we separate it and free it from plasma or deplete it from plasma and resuspend in glucose saline and pool 30 to 35 units, subject them through these medical devices into solvent and detergent treatment. And then through oil extraction and filtration, we remove the solvent and detergent after virus inactivation of the lipid enveloped viruses. And with this, we have a bulk product that probably contains between 3,500 to 4,000 units of factor VIII, depending on the quality of the fresh frozen plasma. From the cryopool plasma, we can subject it to caprylic acid treatment, which will precipitate all the proteins except the immunoglobulins. And in the meantime, it is a robust virus inactivation step for lipid enveloped viruses. We pull the supernatant IVIG from 4 liters of plasma. We concentrate them by ultrafiltration, and then we do the assay to obtain mini pool IVIG. And then under development is another device to produce prothrombin complex concentrate and subject it to a solvent detergent treatment as well. So this is one of the devices that's already under licensing or CE marking. It is the solvent detergent cryoprecipitate virus inactivation, where we can see in the first bag, we can pour the 35 units of the cryo under laminar flow. We subject them to solvent detergent treatment and then extraction by oil, and then filter them through 2 filters, carbon activated filter and microbial filter, which to a great extent purifies the resulting cryoprecipitate into the quality of the intermediate purity factor VIII. We assay the content of the factor VIII per ml, and based on this, we allocate into these small bags and label them with the dose that we require, either 250 international unit or 500 international unit of factor VIII. We can also assay for fibrinogen, foam Willebrand factor, and factor 13. For the mini pool intravenous immunoglobulin, it consists of 3 sets of devices. The first one is for the pooling 2 units of plasma, subject them to caprylic acid virus inactivation and immunoglobulin purification. And it comes in a set of 10 bags so that we can process about 4 liters of plasma. Then the supernatant is subjected to, after separating it by heavy centrifugation, into ultrafiltration through this ultrafiltration device. And then finally, the concentrated immunoglobulin solution is subjected to filtration through activated carbon and bacterial filters to purify it to the grade of the pharmaceutical product. Assay it and then allocate into the bags. We usually concentrate to 5%, and we each bag will have 2.5 grams of IVIG in a volume of about 50 ml. So this is these pictures of the different components of the devices: the sterile bag cascade, the filters, the solvent and detergent, and the oil extraction reagents. And in order to establish this technology for a production facility, you need to have a blood establishment licensed by the National Regulatory Authority and to register these medical devices. And with this, you have a production facility for mini pool plasma fractionation. Some of the experience about the use of this in our country, Egypt. In In 4 years, we processed about close to 300,000 units of dry cryo, utilizing about 8,200 medical devices and producing close to 36 million units of factor 8 at a cost of $2.5 million. If we were to import the same amount, this would have costed the country $5.4 million. So this resulted in a cost saving of about $3 million. In the meantime, the product was transfused to hundreds of patients with hemophilia. And we, in our blood or hemophilia treatment center, we are treating about 20 pups since more than 10 years on regular low-dose prophylaxis. The boys are doing great, and strikingly, none of them developed inhibitors, which is another added safety feature. None of them experienced any adverse events or transmission of viruses. Regarding the clinical experience with the mini-pool immunoglobulin, a study was done between 4 universities in Egypt as a randomized multi-center study studying the safety and the efficacy of mini-pool intravenous immunoglobulins versus standard immunoglobulins in children 1 to 18 years with immune thrombocytopenia. And this included like 75 kids, 25 were on standard IVIG, 25 on the mini-pool IVIG, and 25 observational. And the study concluded that the safety and the efficacy of the mini-pool and the standard IVIG are equivalent. Another study that's about to be concluded in the Astute University Hospital, studying about 20 kids with primary immunodeficiency due to different disorders. And as you can see, after 6 months, that with the once a month 700 milligram per kg infusion of the mini-pool IVIG, we could establish a basic trough level of 500 milligram per 100 ml, which is sufficient to prevent infection, and reaching a normal peak of during the peak normal level during the peak of the product. The half-life is about 28 days, similar to the standard product, and the quality of life of these kids during the 6 months improved significantly. Finally, the WHO established a new document regarding the utilization of domestic plasma and its qualification for fractionation to achieve a sort of self-sufficiency. And it indicated in countries in which this is a challenging step, the use of the small-scale preparation of immunoglobulins and virus inactivation of cryoprecipitate is encouraged. So in summary, mini-pool plasma fractionation is now successfully developed and implemented. It offers developing countries an access to use domestic plasma for local preparation of plasma products with safety and efficacy similar to industrial products. It can be an intermediate step in the preparation for large-scale plasma fractionation projects. The mini-pool IVIG medical device can be a practical tool to prepare hyperimmunoglobulin from convalescent plasma in epidemic areas, and also to prepare strategic products such as anti-hepatitis B and anti-D hyperimmunoglobulins. With this, I would like to thank you very much for your kind invitation and wish you a very successful conference. Thank you.
Thank you so much, Dr. Magdy, for a very enlightening talk. And now we move on to our next speaker. Her name is Dr. Hina Qureshi. Dr. Hina Qureshi is the head of Department of Pathology at the Kidney Center Postgraduate Training Institute. The main highlight of her career is that she has She has an active participation in the accreditation of the laboratory sections with ICIA, AABB, CAP, and CBAHI. This is the main basis for the next talk, where she will be speaking on on AABB accreditation of blood centers in Pakistan, a dream or reality. Thank you so much, Dr. Hina.
Assalamu alaikum everyone, and a very good day to all. Today I will be discussing on AABB accreditation of blood banks in Pakistan and whether it is a dream or one can make it a reality. This discussion will actually outline a little bit about AABB, why accreditation is required, AABB standards and the process of accreditation, situation in Pakistan with the Safe Blood Transfusion Program, and then we will conclude our topic. AABB is a journey over 75 years. And on April 16, 1947, there was an incident of explosion in Texas City that led to the foundation of AABB. The victims were treated with plasma and a lot of blood was acquired from other blood banks. However, some of the blood banks refused to provide the blood. Some of the blood banks could not arrange it due to certain reasons. So after the incident was over, the administrative assistant of the blood bank that was demanding the supplies, her name was Magdy Saunders, she was a law graduate. She sent a survey of questionnaires to address these issues. One of the questions that she asked was whether the blood banks were interested in joining a national association. 78% of the responders nodded with a yes, were very positive about this. And then a meeting was called. In that meeting, she presided and concluded that with this statement, which you can see in the this icon, ladies and gentlemen, I have just been handed a request signed by 68 of you dated November 17, 1947, which I would like to read. The undersigned urgently requests that the Blood Bank Institute seriously consider at the earliest possible moment the formation of an American Association of Blood Banks. So this is how the foundation was laid. This was the realization of a dream held by many blood banks for several years and then later, since 1957, the AABB started setting up standards to optimize the health and safety in the blood transfusion. American Association of Blood Banks now has a very wider scope and is now named as Association for Advancement of Blood and Biotherapies. It is a connected community dedicated to advancing transfusion medicine and biotherapies from donors to patients and from lab to bedside. Currently, there are more than 80 countries who are members of AABB. And so why accreditation is required? Accreditation is basically required to maintain high quality facilities, and it is needed to monitor safety, effectivity, appropriateness, easy accessibility of its services, efficiency of that facility, and whether it is patient-centered and consumer-friendly. So AABB in 2005, this association was started to be called by the acronym AABB, which became a symbol of authority and distinction, and started to set standards, high standards of safety and health facilities of blood banks, and accreditation became a reality. AABB accredited blood banks are recognized throughout the world for providing quality products and services. So what is the process of accreditation? Well, the process of accreditation is it begins actually when you apply for this process. Then there is a pre-assessment. The pre-assessment is in questionnaire form, and the pre-assessment has the same standards that they will assess you on for the accreditation, and you will have to provide evidences against that particular standard, that how your facility is doing it. Then the pre-assessment, when it is completed after multiple correspondences, then the process of assessment begins. And after the assessment, if there are any corrective actions to be taken, those are addressed. And in the end, the decision on accreditation is achieved. Reassessment is done when you provide the corrective actions. The corrective actions can be provided within the 30 days of the observation that the assessor may put you through. So these recognized standards are basically the minimal requirements. These are and are assessed through evidence-based practices, as I just said, and compliance to the required standards is assessed. Then there is peer review by the experts, and variance to any standards can be submitted with evidences and references. This is, I know, seems a little busy slide. I actually worked in my previous institute, that is Dr. Sulaiman Al Habib Medical Group, Riyadh. I, as the head of the blood bank there, achieved this AABB accreditation. Actually, there were back-to-back 3 accreditations going on month after a month, and we were very busy at that time. And we were very much prepared, and how we did that is a different story. But I'll just go through all these pictures. I'm sure I do not have a pointer, or I think I can move this cursor here. So after organizing ourselves, when we had applied and they had sent us the standards, a pre-assessment was done. In that pre-assessment phase, we had already prepared our policies, the processes, the plans, the protocols, the forms, whatever the standards were, we did that. And with that, it was just not a paperwork that had to be done, it had to be implemented as well. So staff training and everything was done. So after the organization, the initial organization, when the assessor was called, we sat together. We first, he just first went through all the policies with us. Each and every standard was seen on the paper first, and then a ground reality check was done. So this, you can see the ground reality check is going on. And after that, both my blood bank and the hematology team were quite actively involved in all this. And after that, an exit report was provided from the AABB, and we were 99-point-some%. I exactly don't remember the figure, but we were quite good at that. And a single or 2 observations were there, and we made the corrective actions, and then we were accredited. And you can see that we were AABB accredited, we were CAP accredited, and we were CBAHI accredited as well. So coming to the process of accreditation. And of course, it was all publicized in the newspapers in Saudi Arabia. Assessment. So for the assessment, as you had seen those pictures, that was Mr. Ahmed Godin that assessed our, that surveyed our facility. And of course, a team or even a single surveyor does the ground checks, and of course, lodging, boarding, everything has to be arranged for them. All the required evidences are organized beforehand by the institution to be surveyed, and usually the survey goes for 3 to 5 days. The staff must thoroughly know the institutional policies and or processes and or protocols or plans, as they will face the assessor for the on-ground implementation. So as you can see, these are the QSEs. QSEs is the quality system essential that are required by organizations. According to the NCCLS guideline, according to the CLSI guidelines, and there are 12 quality system essentials that has to be followed. So these 12 quality system essentials are all covered by the AABB standards. AABB standard book is published once per 2 years or something like that. And it is all available on the website. On the information is all available on the website of AABB, and it covers the organization, the resources, the equipment that is used in the blood bank, the supplier and the customer issues and chains. The process controls, this is a very vast topic, which covers the general processes, the collection and the production of the components, the transfusion services related activities, and then all the documents and records are checked. The deviation and non-conformances and adverse events are seen, and if there are any other assessments which have been done, like internal or external assessments, like we have already had the CAP assessment earlier than AABB, and then process improvement and continuity of action, and then facility and safety. All are these are the quality system essentials that are required and are there are standards set in the AABB. So taking the first one, the first quality system essential in the standards book of AABB, organization is a must. It has 7 standards. And when I have written 7 standards here, it doesn't mean it just have 7 standards. Those 7 standards may have sub-standards and sub-standards as well. So it's not that it's that easy. All those standards have multiple other sub-standards as well that have to be fulfilled. The organization means that how does the executive management works, the director of the blood bank, all the quality systems implemented in the hospital or in the facility of the blood or in the transfusion service. All the policies, procedures, processes, how do they work about the operational continuity with risk management addressed and emergency preparedness, whether the facility is prepared for any kind of emergency. This could be an IT emergency, this could be a bomb blast, or it could be related to any kind of emergency that you can think about in a blood bank. So downtime systems should be there, and all the staff should be thoroughly prepared for any kind of emergency, fire or anything. So, and one more thing, that the organization must, all the staff must be able to contact the AABB, and the contact information of AABB should be displayed such that any staff can contact them as an anonymous person and can tell them about the safety and the quality. If they have to address any safety and quality issue about the facility, they can contact them. And of course, the customer focus. Standards against this quality system essential, that is resources, which cover the human resources, and the human resources, the qualification of those personnel working in your facility, whether they are trained sufficiently or not, their competencies and their personal records in their HR files. The next quality system essential is the use of equipment in the blood bank, in the facility, and it is covered standards and multiple sub-standards again. The equipments, how the equipment is selected, how it is installed, the installation qualification, the operational qualification, how it is used in the department. The unique ID has to be provided on each and every equipment. If the equipment is not under use, if it is not used, then you have certain standards on that. The instrument must be calibrated. Preventive maintenance should be done according to the manufacturer's advice, recommendations. And all the investigations and failures or corrective actions should be taken if there is failure or breakdown of the instrument, and calibrations must be done accordingly. Similarly, the storage devices for blood component, reagent, tissue, and derivatives. Alarm systems should be in place. 24-hour alarm systems should be in place. If there are any warming devices for blood and blood components, these should also be addressed under these 9 standards. And the information system connected to all this equipment. Then there is suppliers and customers issues, which is addressed as the quality system essential. And there are 2 such standards on this: how the supplier is qualified in your institute or in your facility, whether there are agreements made or not, what is covered under those contracts, and then the whatever whatever supplies that you are getting, there should be incoming receipts and inspection and testing of all the supplies. Process control, as I previously also said, it's a very vast subject. It's a very big component of these standards, and encompasses about 30 standards with multiple substandards, which address general as well as everything that you can think of in the blood bank going on, the policies and the procedures on donors, on recipients, transfusion, anything that you can think about. Each and every document has to be set accordingly, and not just the documentation, but also implementation according to the policy that is there on the paper. So staff must be thoroughly knowing each and everything, inform consents from the donor. How do you qualify the donor, and the examination of the donor at the donor aspect? Then how do you process the blood in the blood bank? How do you make the components? Each and every single thing. How do you go ahead with the pheresis procedures? So each and everything is covered under these 30 standards. You name it and you have it. So after these 30 standards on process control, there is the other quality system essential, which is covered under 2 standards and multiple substandards again, the documents and the records that a facility has to keep. How do the facility keep the record? How the change of record is controlled? If there are any electronic records, which of course for AABB accreditation, electronic records are must. And then there is how the storage and the destruction of records or archival of the records is taken place. There are multiple standards on that. And then there is a record retention and maintenance substandard, which addresses that which documents or which records should be retained permanently, indefinitely, and which records can be retained for certain number of years. If there are any non-conformances, these have to be addressed and documented. If there is any fatality, be it a donor, be it a recipient, that has to be reported. And then there is a classification, a thorough classification of adverse events, starting from a simple adverse event till the sentinel event or even death. And then there could be, these events could be related to donors, these events could be related to transfusions, and then how to proceed with the evaluation and assessment of these transfusion reactions, how to look back, why to look back, what to look back. Everything is covered under these standards. Then, and just as I told you earlier, that any internal or external assessments that were done or are being done, that has also to be assessed. Process improvement takes place by way of corrective action and preventive action. And the facility, how it is it a safe facility or not for the staff, for the donors, for all the stakeholders, the environment is safe or not. This has to be addressed as well. So what about the situation in Pakistan? History of blood safety system reforms in Pakistan dates back some 3 decades ago. In late 90s, transfusion transmitted diseases were included in the scope of the National AIDS Control Program, and later 1997 to 2004, the Safe Blood Transfusion Act was approved with the formation of the provincial blood transfusion authorities, which kept a check on transfusion setups working in the provinces as per the defined standards. Closure of a number of blood transfusion services was carried on due to substandard services. Project NBTP was established as an independent authority to ensure safe blood transfusion all over the country, and other major developmental processes were addressed. In 2010, the Safe Blood Transfusion Program was launched as a national infrastructure of blood banking, with monetary assistance from the German government and technical aid from the WHO. The most significant achievement of the NBTP was the formulation of a national strategic framework for blood transfusion services in Pakistan, which was officially approved in 2009. A national steering committee was established that not only started to conduct surveys, but also organized training courses, which is a very, appreciable thing. And quality management was taught in various provinces, in various blood banks, and it's a continuous effort by the federal government. In 2013, the WHO's survey reported, 2013 to 18, a survey was reported by WHO in which more than 50% of the blood supply is from family replacement or paid donors. And it still continues. While the blood donations rate is about 5 donations per 1,000 people. There's existence of only 25% transfusion committees and in the low-income countries. And of course, Pakistan is included, and I'm sure it is much lesser than this 25%. Pakistan, as we know that it's a developing country with an annual blood collection of 3.5 million and rate of approximately 1.5 million per year, compromised Haemovigilance process due to lack of standardization, insufficient knowledge or understanding of the donation and transfusion process from one way into another, despite the efforts by the government of Pakistan, has increased the transfusion transmitted infections. So I conclude that accreditation may seem a big fancy word that simply means qualifying certain set standards. However, optimization of donor and recipient safety and outcomes of the transfusion services are utterly required for a successful evidence-based patient blood management program through measurable improvement indicators. Now, be it AABB or be it our own national standards that a blood bank or a facility has to be measured against, it has to be done. It needs to be done. So AABB accreditation can largely benefit. We can largely benefit from that. And it can be initiated by the institution itself as a voluntary activity or at a national level for further improvement of the overall blood banking and transfusion services of Pakistan. So whether it is a dream or reality, it's up to you. How do you act in time? Because doubt almost kills many dreams than failure ever will. So determination, perseverance, and hard work is important. A way forward that I see is that we can collaborate with certain institutes, organizations, and associations, like in our part of the world, the AATM, the Asian Association of Transfusion Medicine, can be collaborated with because the AABB accreditation costs around $12,000 per accreditation, and which is a 2-year accreditation, which covers 2 years of accreditation, right? So we can go ahead with AABB certification. Certification, as you know, it's not accreditation, right? And it only covers certain fundamental standards. Not all the standards have to be covered, but those which are very important, very basic, and very fundamental, these can be covered by this AABB certification. The difference is also that it is not on ground. Everything has to be submitted online. So there's an online approach. It is cost effective, contrary to AABB accreditation, which takes, I told you that it's $12,000. This AABB certification can be done in $4,000 for 2 years. Collaboration with other organization is a way forward. Thank you so very much. The floor is open for questions, if any questions.
Right. Thank you so much, Dr. Hina. It was a very enlightening lecture, and we'll take the questions at the end of the session. So now we move on to our next speaker. Her name is Dr. Saba Jamal. Dr. Saba is the Director of Transfusion Services at Indus Hospital Health and Healthcare Network. She is also a chair of pathology at Indus Hospital. She is the CEO of Zavia, which has formed a blood banking software, which is called Panacea, which is quite famous in all the regional blood centers in Pakistan. Additionally, she is leading the regional blood centers in Jamshoro, Multan, and Bahawalpur. Dr. Saba will be talking about the implementation of blood safety in public sector hospitals between reality and ideals. Please, Dr. Saba.
Assalamu alaikum. I'm Dr. Saba Jamal. I'm Director, Blood Transfusion Services and Chair Pathology of Indus Hospital and Health Network. I would first like to start my talk with thank you, a gracious thank you to the organizing committee of Pakistan Society of Hematology for giving me this opportunity to present this presentation. And I would like to move on to my topic now, which is implementation of blood safety in public sector hospitals between reality and ideals. I would start with the disclosure of that there is no conflict of interest in this presentation. And I would like to start with the background. IHHN blood transfusion services has basically two types of blood transfusion services. We have our own site, which is the Indus Hospital Blood Center at Karachi, where it is managed by us and all the finances and funding is raised by Indus Hospital and Health Network team. RBC Multan is connected to Nishtar Hospital Blood Bank, which is HBB, of about serving about 1700 bedded hospital, which is the Nishtar Hospital, MIKD, which is Multan Institute of Kidney Disease, and we are also connected to the Rajab Tayyab Erdogan Hospital and in Muzaffargarh, and about 5 Tehsil headquarter hospitals. RBC Bhavalpur is connected to the Bhaval Victoria Hospital, which is a 1500 bedded hospital in Bhavalpur. We also provide blood to its Jubilee Hospital, which is a gynecologic hospital. We partially provide some products to the civil hospital, Bhavalpur, and we are providing complete blood products to the Thalassemia Center in Bhaval, Victoria. The Regional Blood Center Jamshoro is connected to Lums University Hospital and Civil Hospital Hyderabad, Civil Hospital Thatta, and Civil Hospital Badin hospital blood banks. So this is a larger network. The Karachi site provides blood to multiple sites, its own hospital as well as to multiple other hospitals. So this presentation is about how we have tried to achieve international standards in both our public sector hospitals and sites as well as our private site. The main challenge is that people think that you can achieve certain standards within the private sector sites and not in the public sector sites. And we will discuss how it was achieved and what are the challenges. Of course, there are challenges, and I will be elaborating the major improvements in the blood system that has been made in the public sector in Punjab as well as Sindh. We will now go on to the different processes which are a part and parcel of the blood banking process. We will start with request generation and sample collection. In the generally in the public sector hospitals, a request is raised on any slip of paper they can catch hold of, which can even be partial half of a paper, and incomplete patient details are given, incomplete orders are scribbled on it. So we basically, how have we modified this? In Karachi, this is an ideal system where we have an electronic, the entire hospital has an HMIS and is a paperless system, and we have electronic request which is raised in a hospital management information system and transmitted to the blood bank management information inside the blood center. However, in the public sector, as we are not running the main hospitals, and most of these hospitals, in fact, all of these hospitals either don't have an HMIS or a very rudimentary HMIS is present. So we do not have, even though we do have a blood banking information system, which is identical to the system in Karachi. We do not have any electronic system that we have a control over in the hospital. So what have we done? We have basically created printed request forms, which the hospital blood bank provides to all the wards. If we go on to the patient sample, what happens when we take over a system in the public sector? We find that most of these sites, samples are drawn in syringes, either with incomplete labeling or without any labeling. There are a large proportion of samples that are sent with a paper and unlabeled syringe. In Karachi, uh, patient sample is not drawn is drawn basically by the phlebotomist by using a bedside label printing system. This is on a smartphone. Our phlebotomist basically scan the wrist bar coded wristband of the patient, and the order comes is transmitted to the phone. They then decide on the number of vacutainers. This is also for the lab tests, and hit on the print label. They have portable printers, and these portable printers, which are basically linked with these telephones through Wi-Fi and Bluetooth, and these printers then print the MR number and all the details, the labels, and are printed at the bedside. And so we have basically in Karachi eliminated the chance of a mix up of the sample. However, in the public sector of a hospital, as I have discussed before, that the whole system is not under our control. What we have done is that we have requested written labeling on the vacutainer tubes, which is non-negotiable. The blood donors are addressed as where do we get the blood? In Karachi, we were able to achieve 94% voluntary blood donation of 27,000 prior donors collected annually prior to COVID. In COVID, it has gone down to about 84 to 86%. We are now again going up as we are learning to live with COVID. Whereas in the public sector hospitals, uh, where when we take up a site, over there, usual step is that families basically arrange directed donation. Patient's blood group is done, they are informed, the family is informed what the blood group is, and then they have to make available blood group identical donors. However, what we do is that we basically ask for replacement donors, but we say any group blood donors. And we do not do use directed donation. We basically do the cross match issue from our issuable stock and our inventories. Frequently transfused patients in these sites, like thalassemia patients, cancer patients, burn patients, they are provided without replacement donors, all blood products through our VNRBD project, drawn into these sites by these regional blood centers. How do we proceed with selection and draw? Minimal or no pre-draw screening or physical examination is performed in the public sector hospitals when we basically take over the sites. We all know the patient comes, they are asked, "Aapki tabiyat theek hai?" The donor comes and they are asked, "Aapki tabiyat theek hai? Koi hepatitis, etc. to nahi hua hai, letiye aur draw ho jata hai." What we have proceeded with is we have a blood banking information system, and it's an identical one on all sides. We have detailed electronic questionnaire along with the physical exam, and all data is entered live at that point on all sites, whether it may be public or Karachi owned site. We do our hemoglobin by portable hemoglobinometers, and it's not done on copper sulfate. We do our physical exam in detail. We also get our consent, and all of that is saved electronically. And this is an identical system that we have been able to achieve on all sides. Donor draw is drawn in the public sector hospitals without aseptic techniques. We have been able to implement aseptic technique across the board on all sides. How do we draw? In which containers do we draw? Usually in these public sector sites, either single or double bags are available, or the patient's family is told to buy a bag from the market, which the condition of which is not known. We basically in Karachi, we have introduced diversion pouches, and we are basically drawing either on triple, or most of it is drawn on quadruple bags, as we are basically making a lot of cryoprecipitate and donating into the hemophilia center, as this is a NAT tested product, very precious product. And this is and that's why we are using a lot of quadruple bags with diversion pouches. However, in the public sector, we are using double or triple bags and some quadruple bags for cryoprecipitate and supernatant, but we are unable to introduce the diversion pouches. So it's not the ideal. As we go on, while the unit is drawn, usually in the public sector hospitals, when we take over, the blood bag mixers are not used, or very poor quality blood bag mixers are used, whereas we use on all sites. Alhamdulillah, we have been able to achieve this. We use regularly calibrated blood bag mixers. These are also calibrated when we go on the camps. Regarding the TTI testing, most of the sites in the public sector, and specifically in these um, rural or semi-rural areas where we have taken over. Previously, the rapid devices were used officially, and we all know a lot of time even these rapid devices are not used if somebody is not monitoring. And many a times the patient's family is told to buy these rapid devices, and we know the standards. And anyways, rapid devices are not recommended. What are our standards on all sides? CLIA has been implemented. We are doing hepatitis B surface antigen, anti-HCV, hepatitis and HIV, P24, HIV 1 and 2 antibodies, as well as syphilis on CLIA, and malaria is done on rapid device. We have also implemented supplemental confirmatory testing in these sites. However, Karachi, we have been able to achieve the ideal, meaning we do NAT testing one-to-one donor, and it's not pooled, and we do 100% platelet cultures. All our products go, platelet cultures are undergo all our platelets undergo platelet culture. We go on to how the donor testing. In most of the sites, only in the public sector and in many a private sector also, forward blood grouping is performed either on tiles and slides, and that's all. No reverse is performed, whereas in our system, all sites we have forward and reverse blood grouping is performed by tube method. Week D testing is performed on all donor testing. That is an essential international standard. We do routine screening for Bombay group by putting O cells in the reverse group, and a blood group pre-confirmation is performed using bag segments. Therefore, 2 blood groups are performed on all sites. And then the blood bags are labeled. However, in Karachi site, this is done on tube testing in all sites. Karachi site has moved on to automated blood grouping. We also perform red cell antibody, allo antibody screening, single cell, pooled cell on all donor plasma by gel method. So that is where we have been able to achieve the ideal, and this was achieved a few months ago. Availability of components in most of the government sector hospitals, when we took over, mostly whole blood was available and issued. And initially we faced this challenge of where the clinicians demand whole blood, but we do basically, initially we do provide them whole blood, but then we start to give them counseling sessions. The heads or hematologists go to all the wards repeatedly, regularly, and discuss component therapy. And Alhamdulillah, we are able to achieve 99.9% red cells in almost all the sites, along with platelets, FFP, cryoprecipitate, and cryosupernatant. All of these are available freely. We move on to compatibility testing. That is also very interesting. In most of the compatibility testing in the public sector hospital, patient forward blood group is performed either on tile and slides, and not much is done beyond that. And what we do on all sides, we perform tube testing, and forward and reverse blood grouping is performed. We screen for Bombay group by putting O cells, and we do use RH control as a routine for AB cases, AB positive cases. As we move on, what about cross match? Most of the sites in the public sector hospital either perform a slight cross match, which is without Coombs control, and we all know how reliable that is, or a new thing has been invented which people call slide cross match. And that cross match is performed on a slide. That basically is something home brewed and has no value. What we have achieved, alhamdulillah, is gel cross match on all sides. And if the gel cross match is incompatible in these government sector sites, then we move on to red cell allo antibody screen and identification in the incompatible cross match, and antigen negative unit is issued. However, in Karachi site, we do allo antibody screening on 100% patients before the cross match. We are trying our best to move on to electronic cross match, and hopefully this will be achieved in the next quarter. As all targets have been achieved, we are just validating all our data to see that this has zero risk. Moving on to when the unit comes into the unit verification, from we take it out of the quarantine, documentation, labeling, traceability. We know no formal unit verification or visual inspection is done to bring the unit out of quarantine into the issuable stock. We have separate areas, and issuable stocks are kept in separate areas, in separate identified fridges on all sides, and very strict unit verifications are performed, and strict quarantining is done before the unit verification. And this is all has been implemented on all sides, including very detailed visual inspection of all units. In most of the public sector hospitals, if we move on, there is either minimal documentation or complete lack of documentation, and most of the sites have manual blood bag labeling, which is very haphazard. There is no traceability of individuals handling these the units at different points, and there is no documentation that is left. We have implemented an electronic blood banking blood banking management information system, which is ISBT 128 barcoded compatible, and this is implemented into all our RBCs and HBBs, and they are all interconnected. In the public sector hospitals, the blood bags do have zero traceability. We in Karachi sector, we have complete traceability from the vein of the donor to the vein of the patient, because we have electronic phone compatible bedside transfusion unit, which we call Vitalia, and everything, all data goes into that. Whereas in the public sector hospital, we have only been able to ensure electronic traceability from vein of the donor to the bedside where we deliver our units, and where our staff takes the blood unit and delivers it to the bedside in the wards, to the patients, not to the family, but to the doctor, and we get the receiving. So we have all of that traceability available, but we do not have the traceability of the transfusion, because that system is not under our control. Cold chain maintenance is another very important and neglected topic in our system. Most of the blood banks, even our private blood banks, if it's not in the hospital, patient's family get the blood immediately after draw, carries it in the shoppers, and then take it to the wards where they are put in the household fridge and not in the regulated and monitored fridges, blood bank fridges. And that's the routine throughout the country. What Alhamdulillah, we have been able to achieve is that all the blood units are stored in the monitored blood bank fridges. Units are not given to the patient's family. They are transported to the bedside by the blood bank staff in the public sector hospitals, where we have hired blood distributors, and they have the specific JD, and they take the blood within cold chain boxes. And in our Karachi side, the hospital ward porters come using their cold chain boxes, and it's supplied to the patient's bedside. We don't even issue blood to the operation theaters in the public sector or at Indus. The OT blood is stored in the blood bank fridge that is inside the OT theaters, which is in the region where there are OT complexes, and our staff sits there, and if the blood is required, we then issue it and bring it out of the blood bank fridge. So the cold chain is actually maintained strictly from vein of the donor to the vein of the patient. Moving on to the quality assurance, which is a very important aspect of blood banking. And we all know in most of these sites, there is no quality assurance, where, as in all our sites, we ensure daily serology and Tti testing quality assurance. We ensure the biomedical engineering ensures the maintenance of all the equipment, the PPEs. We ensure that quality assurance does the audits, which is CCTV audits and physical audits, to ensure that all quality assurance is being performed and methods are being followed. There is no concept of reagent lot to lot verification when new lots come in our, as we order centrally from Karachi. When a new lot comes, it comes to Karachi first, and lot to lot verification is done, and then it is transported to all sites. So we have implemented lot to lot verification for all sites. We are enrolled in CAP proficiency testing on all sites. There is regular PPMs performed, biomedical engineers are available on all sites. Our heads are not medical officers, which are only MBBS in public sector sites. We have FCPS hematology on all sides, and now we have now also have second backup hematologists. Our all staff undergo extensive training with competency assessment, annual trainings, and in-service exams achieved on all sides. There are dedicated blood donor mobilization teams on all sites with annual targets. So voluntary blood donation is being collected with a rising target every year. Identical systems have been implemented in almost all the sites, and the only difference is in NAT testing, platelet cultures, diversion bags with diversion pouches, allo antibody screening of all patients, because this requires extensive funding, which Indus management is committed to do, because our motto is quality care free of cost. And interestingly, this standard of unit in Karachi is provided to the patients completely free of cost. The same is all the other sites where the patients get completely free of cost. We get the funding from the uh, government. But the patients get it free of cost, and we ensure that no money exchanges. Thank you very much, and I hope I've been able to explain that there are many, many things that do not require money and require consistency of efforts, and those can be achieved in the public sector hospitals also. Thank you very much.
Thank you so much, Dr. Saba. That was very informative. Now I move on to the next speaker. The next speaker is Dr. Nuzhat Mushahid. Dr. Nuzhat Mushahid has had 10 years experience of transfusion medicine. She was trained for, I think, twice or thrice at UK during her career at Armed Transfusion Institute of Armed Forces. Dr. Nuzhat is the CEO of P First Solution. She has designed her own blood banking software, and today she'll be talking about the about hemovigilance in the setting of fragmented blood transfusion system in Pakistan. Dr. Nuzhat.
Bismillahirrahmanirrahim. My name is Professor Brigadier Nuzhat Mushahid. I want to thank the organizers for inviting me this talk on Haemovigilance in HaemCon 2022. The topic I have selected is a relatively new development in the science of blood transfusion. However, it forms the basis of many risk mitigation strategies and many of the patient safety initiatives, as well as donor safety. This remains very underdeveloped and rudimentary in our country. And the reason being, one of the reasons being lack of awareness. It is only possible to reap the fruit of this initiative once it is done at a very large scale and data is managed in such a way that it leads to tangible and objective solutions to something. History of blood transfusion can be conveniently divided into two main eras. One of them we can label as pre-modern and modern era, and the watershed being the Second World War. There are many milestones that I have listed here. However, the most important of these is the aid crisis, because the way it shook the confidence of people in public health safety and mistrust of the governments finally led to a lot of attention by the states on this science of transfusion medicine. So entire blood chain is prone to risk and danger, but it does not mean that we should undermine the fact that remains a life-saving treatment which forms the basis of development of many of the medical specialties. So we need to have a balanced look, but at the same time, we should also strive to reduce the risk, to minimize the risk in order to keep on reaping the benefit of such a useful therapy for which no alternative exists still. Since it's a huge undertaking for any country, so therefore the states are responsible for ensuring the safety and availability of the blood. And what they do is either the state is themselves take the responsibility of delivery of the service, as happens in the European country, or they can outsource and delegate the responsibility to a credible organizations and then strictly regulate the service, as it's seen in USA, where this is undertaken by American Red Cross. And many directives and guidance are available both from international organization like WHO, as well as many national and local guidelines. This is not an exhaustive list. If somebody wants to search for the international publications on that, these are open source and easily available. There is a great need for a data on predicting the transfusion risks because this forms the basis of learning and looking at the safety, existing safety, and move on to aim of zero risk from blood transfusion. Maybe theoretically speaking, maybe each unit should be subjected to elaborate testing. But we know that this cannot be comprehensive enough, and neither it will be, and maybe it will lead to destruction of the units, and that is no longer practical. We can estimate, and there has been an attempt at estimating risk from the characteristics of the donated units and the recipient population. And we have seen mathematical modeling which estimates the likelihood of a unit containing an infectious agent in order to estimate the risk of transfusion transmitted infections. We can look and think about prospective studies, but a huge number of observations would be needed at a larger scale, which is probably the resources cannot meet that need. Retrospective studies are again impossible, where data has been varied, not systematic and based on certain preset criteria. There has been, the events have been collected, recorded with different methods and definition. A practical method of assessment of risk would remain a prospective clinical case reporting. And this is the concept behind hemovigilance. And as defined by International Hemovigilance Network, the clinical case reporting in a way which is a set of surveillance procedures which cover whole of the transfusion chain, from collection of blood and its component to follow-up of its recipient, with the intention to collect and assess the information on unexpected or undesirable effects which result from therapeutic use of labile blood products, and the aim being to prevent their occurrence and recurrence. A hemovigilance system cannot come into, only comes into existence when the data for adverse transfusion reactions are collected through an organized network of reporting to a central office, where the data would be collated and analyzed and evaluated by experts who would recommend appropriate actions for enhancing the blood safety. If you look at the hemovigilance history, that how it has evolved, started off in France, mandated by legislation in 1993. And later on, other countries joined in. Some of the countries have voluntary reporting systems, like in UK, and later they moved on to mandating that reporting system. The hemovigilance organization and design models basically are because the way it is covered by legislation, whether it is the designs may be such that it calls for mandatory or voluntary reporting. It can be centralized or decentralized system, and it also depends upon the governance structure that hemovigilance system, which is built on in an individual country. So these are all the stakeholders in ensuring the governance of and setting up of the system. And this table just highlights the way there's a relationship between different authorities in a European model. So to start off, we defining would include these three domains. That is, the adverse events have related with the transfusion need to be defined uniformly and have a consensus on that. The adverse event severity that means the impact of those events on a patient, and also the imputability of the event. How strong is the causative link to the transfusion? So the terminologies that has been coined and described are adverse event, the incident, the near miss. So this slide just briefly shows you relationship between these three domains. Further, these adverse reactions are classified on which by the International Hemovigilance Network, and it is widely adopted, where this acute and delayed is differentiated based on the time. And then this is a convenient pathophysiological classification where the reactions are divided into immune-mediated and non-immune-mediated. The gravity and severity of the adverse events have been graded from 0 to 4, depending upon the seriousness of morbidity. Imputability means establishing the relationship between the adverse event and the transfusion that happens in the recipient. Since the patients who are admitted are undergoing so many other interventions, so it is not always that the blood transfusion is responsible for many of them. So it is important to establish the causative relationship between the blood transfusion and the recipient. So international hemovigilance collaboration data of this scale has proved that blood has never been safer, which is never safer than what it is now. And they are at least in the developed countries, and many of these safety initiatives are because of the programs effective and successful Haemovigilance program. Now coming to our country, the fragmented blood transfusion system in country is delivered through varied stakeholders and sectors. And I've borrowed this slide from Dr. Saba with thanks. And it just summarizes that all these sectors playing and delivering the blood transfusion service in the country is fraught with so many problems. Fortunately, the reforms took place with the help of a German government and started off in 2008. It met some setback after 18th Amendment because of delegation of the health responsibility to provinces. However, the progress did happen, and Safe Blood Transfusion Authority formulated the National Blood Policy and Strategic Framework was written down for 2014 to 20. Broadly speaking, this is a broad framework in the way the blood transfusion system has to be organized and countrywide. The responsibilities of different stakeholders, but the forefront at the level of the service delivery are the blood banks and blood centers who need to commit to the safety and efficacy and quality, as well as commitment to safety and efficacy and quality by the clinical services. This, of course, remains the much weaker as compared to some progress, tangible progress, and a significant progress made on this side. The final program is to construct total of 30 RBCs. So far, 11 has become operationalized and 10 are under construction. The real challenge, however, remains that the delivery of service, successful service and in a public sector to run these RBCs and hospital blood banks successfully in order to ensure safety and availability and quality of blood products. Now I'll want to draw the attention of the audience to the legislative framework, and this is I'm starting off with the legislation, Punjab Blood Transfusion Authority Act 2016. This amply emphasizes the Haemovigilance and it provides a very good framework and basis and blueprint to make a progress if we have will to actually make a progress and realize the importance of it. So here, not only it has been defined, it also has explicitly stated the need for blood establishment computer software. And repeatedly, it alludes to mandatory donor and recipient haemovigilance. Similarly, it has probably mandated the haemovigilance, and punitive and corrosive actions need to be taken, and this is covered in legislation. It does have a provision of regionalization and a wider engagement of many stakeholders if such a program is to exist and a system is to be established. In sense, again, there is a elaborate definition of haemovigilance. I'm not going to read this legislation in detail because these are all open source and available on the internet, and somebody, if he's interested, they can download it and study it in detail with the viewpoint of knowing what is stated there for haemovigilance. Again, emphasis on the technology is there. It also calls for the professionals and expert and professional societies for collaboration and elaboration and lobbying and advocacy. This is food for thought for our society, that how much we have actually utilized and used this very elaborate legislation to furthering the cause of transfusion safety in the country. Similarly, the legislation in KPK also defines haemovigilance and notification system, reporting system. In fact, this is one of the best legislation that has defined the adverse transfusion reactions and gravity and severity of reactions, which is nearest to what the international definitions are. There's also explicit use of technology. In fact, the Haemovigilance system or any other system of reporting and data collection cannot happen these days, especially of that scale, without use of technology and computer and information system. I've listed here the WHO Action Framework for advancement of universal access to safe, effective, and quality assured blood products, which was revised, and 6 stated objectives. What I've done is I've highlighted in green those areas which are where our country has made some significant progress. Gray is the gray text shows where we have yet to make a lot of progress, and it's just a preliminary thing that has been done. And finally, the red is area where absolutely no significant progress is seen and is made. For example, we have appropriately structured, well-coordinated and sustainably resourced national blood system. Regulatory capacity, yes, it has been enhanced, and whether it ensured quality and safety of blood is open-ended. Functioning, and yes, but efficient management of the blood services, again, a gray area. Then the effective implementation of patient blood management to optimize transfusion practices and effective surveillance, haemovigilance, and pharmacovigilance supported by comprehensive and accurate data collection system, partnership, collaboration, information exchange to achieve key priorities and jointly address challenges and emerging threats at global, regional, national level. They all fall in the red zone, meaning thereby that it is hardly we have made any progress, and it is no surprise that all of these actually have a lot of calls for a lot of involvement of the clinical services. Now, setting up of a haemovigilance system would require a meticulous planning to address some critical issues, like the organizational setup with defined responsibility to implement the haemovigilance as a national program. We have to decide which adverse events are to be reported and what comprehensive reporting system we can put in place. Who shall be made responsible for reporting? What mechanism should be put in place for reporting? We have a consensus, uniform definition, dissemination of this uniform, and receiving that data in a standardized format. Whether we should, I don't think so that voluntary reporting is a way forward for our country, at least. Yes, non-punitive approach can be to mandatory reporting as well. Who would be the expert groups and committees for analyzing this data, creating awareness and training program for staff who will be participating in haemovigilance, and this all cannot happen without adequate financial resources. And all this is needed for implementation of corrective and preventive action at the grassroots, and knowing that those action has been taken place. In a fragmented transfusion system like ours, federal and provincial safe blood authorities need to steer the haemovigilance program in light of legislation that we have seen amply supports and mandates haemovigilance program. There should be a close coordination and communication with the Healthcare Commission for the ownership of haemovigilance program, and work for common vocabularies, rules, and strategies. Here we see a lot of gap because of lack of coordination and communication. The key initiative for formation of groups of experts from all of those sectors which are delivering the service should take place, and engage the professional societies. And in fact, the professional societies should be proactive in engaging the authorities to make regulatory rules and committees for implementation. And the foremost in a fragmented blood transfusion system, if one thing that can be done and that need is met and is implemented, probably would make a huge difference, and that is to introduce or mandate the use of information technology in blood banks of all levels, of all sectors, of all scales. Information management systems can be developed by for example, the Punjab has the capacity in the form of Punjab Information Technology Board. They can develop the system and make it available across the province, or they can recommend the existing ones based on compliance with the international compliance, for compliance with the international standards, as well as with the legislation, national legislation and standards. This is the key initiative. If it is taken, that can actually work within a fragmented transfusion system very well. And the authority needs to just focus on mandating the use of a standardized information technology system. Professional societies must also be proactive in prioritizing the hemovigilance, lobbying for rules and regulation, and form working committees, focus on education and training, and voluntary and accreditation standards, support and promote information management system. Obviously, we can't deny the importance of patient advocacy groups and involvement of the civil society. So in conclusion, all stakeholders in country should strive and contribute towards setting up an effective hemovigilance system, which will go a long way in ensuring patient safety and improve transfusion medicine practice in the country. Thank you very much.
Thank you so much, Dr. Nazir, for a very enlightening talk. And now I would like to move on towards the chair and co-chair of the session, Dr. Saleem Ahmed Khan and Dr. Farhat Bhatti, to please provide us some concluding remarks and their comments regarding this session. Dr. Saleem, please.
Do we have some questions? Can we go for questions? Do we have
Sure,
some questions from the audience?
Sure. So we
Let's
right
take
now,
up
so
the
far, we don't
questions
have
first.
any questions from the audience, but yes, we do have some questions for the panelist that I'll be asking. Right. So I would like to direct my first question to Dr. Uzma, if she is online. She is?
Assalamualaikum. Yes, I'm online.
Yes. So thank you so much, Dr. Uzma. We would like to know that what are the challenges, since we just heard a talk about fragmented system of transfusion in our country, and the main problem that arises is hemovigilance system, which is still not well set up in our country. So what are the challenges faced in setting up a hemovigilance system in a public sector hospital, and the steps recommended for its implementation? And just your experience with the regional blood center would be highly informative.
Thank you so much. I would like to thank to the PSH for providing me this opportunity to share my own experience over here. Yes, Shabneez, you are very right. We are going to face a lot of problems while doing or providing services in a public sector. If we come to the hemovigilance, before that, I would like to share my experience about the challenges. Yes, so we have a lot of challenges while working in such setup. For example, I'm working in a remote area of South Punjab, and we have a lot of challenges from public and from the medical personnel as well. If we discuss from the social or from the public, most of the people are not giving, not willing to donate blood due to different social stigmas, like we will have weight gain, we will be having, weakness, we will be having some heart issues. And then I will come towards the steps how we have formulated to cope up with these challenges. Then comes the importance of UADHQ questions, which we ask from the donors before getting blood from them. Then there is another stigma that people usually want their own family members' blood. They usually say, we need this bag urgently. Even they don't have awareness about that we will go for the IDS, testing, then they will be provided blood. So they are in so much hurry. There is basically lack of awareness on the part of people.
So,
And there are some.
Dr. Uzma, so have you ever had this experience of setting up a transfusion committee in the hospital that you are serving? So
Yes, we
basically,
have.
every
Yes, we have.
transfusion.
It was formulated
Yes.
in
Mm-hmm.
2017 when
Mm-hmm.
the Regional Blood Center Bhavalpur was managed by the Indus Hospital. So the hospital transfusion committee is basically chaired by the principal head of institution at all the regional blood centers which are working with Indus Hospital, and it is on the regular basis, and all the important points are discussed in that committee sessions. So
So
a
are
lot of
they
things
are
are
these so are these public hospitals, are they ready to accept you when you try to create hospital transfusion committee meetings and everything in your set in the public setup? Are they willing to accept you?
no, in the start
There is
we had to face a
resistance.
lot of problems.
Yes.
Yes,
Uh-huh.
there was, and there is still at some level. And a lot of medical people, like, they want whole blood still. Instead of
Yes.
our
So whole blood
regular
still remains an
sessions,
issue.
they need, we
Mm-hmm.
want whole blood, we want fresh blood, we want whole blood. And there is
Mm-hmm.
a very important thing is that even the medical personnel are not aware of rationale using of blood products. For example,
Okay.
if the
Thank you so
hemoglobin
much.
is 10, then
Thank
how
you.
much blood is needed, how much platelets are needed. So
So
we
I would
have to
like
do it.
now, okay, so I would, thank you so much. I would now like to move on towards our next question, which is towards Dr. Maria. So Dr. Maria, considering our talk on accreditation, so accreditation is the latest topic which is running in our country now since Asian Association of Transfusion Medicine is also becoming active in our setup. So what do you think? First, it was all about CAP, and now it's all about AABB. It's just related to the talk that we heard. So which is better? Is CAP better? Is AABB better? Which is more practical? What are the cons and pros of each accreditation in your
Uh, thank,
experience?
thank you, Shabneez. Thank you for giving me this opportunity to give my opinion. But I would say, since my experience, I have not experience of getting my considering my lab for ABB accreditation. Perhaps Dr. Hina could answer it better because she has the experience of getting her lab accredited for both CAP and ABB. From my perspective, I think before accreditation, we should also consider, if we cannot pay entirely for the accreditation, we must consider participating in those surveys first and see whether we can go for those accreditations or not. So keeping that thing in view, we tried to participate in CAP service, but apart from the quality aspect, we must consider there's the cost of those surveys. And besides that, we had and apart from the cost, you know, we do participate in RBC. We do participate in external quality assurance program, which is done with the help of the FATME services.
So,
And
which is easier? And what I wanted to get, and any of the panelists can please, if you could just discuss it further. But which is better? Which is easier? Which is better? Is CAP better when you talk about a blood center? Maybe Dr. Saba, you could shed some light on it.
CAP is more related to labs.
Yes.
It has less, yes, they do review the blood banks also, but
Mm-hmm.
their regulations and standards for blood banks are much less than those required by ABB. We have gone through a very extensive review and are trying to meet all the standards. AABB is very, very extensive, and then they need a lot of other data also. So, and
Yes.
again, it's quite an expensive undertaking. It requires platelet cultures, which CAP doesn't require. It requires allo antibody screening of donors as well as patients, which CAP does do an initial uh, accreditation without it. Furthermore, it requires for exemptions of shagas and other SGLT1 screening, it requires a lot of extensive data from that country, which we don't have. We are trying to get that data by testing with the donors, etc. So AABB is very difficult, very, very difficult. In addition to all the testing, it is very extensive on administrative as well as documentation.
Right. Thank you so much.
Dr.
Dr.
Saba,
Magdy. Right. Okay.
Can I,
So Dr.
Shabneez,
Magdy.
can I ask a question?
Sure, sure.
Sure. My question is, what is possible for countries like ours? Because we, in public sector, many of the blood banks, they do not keep budget for these external accreditation processes. So what are the recommendations? I think the organizations which are already accredited, they should support their sister organizations or the other laboratories in these processes. So if they are not even they don't go for accreditation, they should at least be able to participate in those external quality assurance surveys.
Before we even talk about accreditation, we need to talk about proficiency testing. One needs budgets even for proficiency testing, and I think AFIP, General Saleem, and may shed some light on it, has and maybe Nuzhat can tell us some a proficiency testing survey locally prepared in AFIP, but I don't think it includes, other than TTI testing for immunoassays, it includes anything related to blood banking. I personally think it's time to create
thank you.
something locally.
Yeah, I
So
think
Dr. Farhat
here,
or Dr.
Shabneez, let me, I was listening very attentively to what the comments are. You see, we have, if you ask me, both from angle of professional societies like ours, which can contribute a lot, and some other probably non-governmental group which can look into these aspects of proficiency testing. Proficiency testing, which is being undertaken in AFIP, is mainly chemistry oriented. It covers very small aspects of hematology. And there are total about 75 laboratories which are participating in that. Not bad, but that is, very small bit of it. So there's nothing which is dedicated towards this thing. As unfortunately, AFIT had not taken a leadership role there. I'm sure if we all gather and we really use this platform of Pakistan Society of Hematology, which has so extensive membership, all members are affiliated all across the country. We just take initiative and look at the critical areas. I mean, hats off to Dr. Saba. Dr. Saba, that she's
thank you so much, Dr. Nuzhat. Thank you so much. I would like to know your comments on this, Dr. Farhat, please. So, Dr. Farhat, would you provide some of your opinion regarding this?
Well, definitely, hemovigilance, basically, as far as hemovigilance is concerned, what I feel is that the hospitals, they are probably not integrated in the legal framework. So it is actually very difficult for us to really convince the clinicians that they may actually come up with the adverse effects and anything. And the second aspect is about the quality assurance programs. So I think we can cooperate amongst ourselves. For example, we can approach certain organizations which are already doing it, like FIP or any other organization which may actually like to volunteer for that. So, but again, we need to know that actually all of these things, they need a lot of funding, they need a lot of resources. And similarly, we have to develop mechanisms for that so that all the institutes, they are able to participate with that.
Right. So now our Dr. Magdy, Now, this question is especially for you and General Saleem, and of course, Dr. Hassan Abbas Zaheer, since we'll be talking about the use of domestic plasma, which is collected in our country in a large quantities. And since we have we have the concept of regional blood centers in our setup, so that means way more plasma which is being accumulated in our setups. So, Dr. Magdy, I'll start with you first. Tell us that which are the countries, because this has been your setup has been very successful in Egypt, but which other countries have implemented the same setup? This is my first question, and the second question is that it is very successful in hemophiliacs, and after listening to your talk, it has especially the immunoglobulins which working in patients with immunodeficiency syndromes. So that's another aspect of these mini pool. So, do you think that this technology is only well suited for places where there's a huge collection of plasma, or such as regional blood center, or would it be okay for large commercial hospitals also? So, these are my two questions towards you, and then Dr. Saleem, please give us your opinion on that. You are on mute, Dr. Magdy.
Now you can hear me?
Yes, now we can
Perfect.
hear you. Thank you.
Perfect. Sorry for this.
No
Actually, I mean, talking about this technology, as you know, this technology is produced by a Swiss company, which produces the medical devices. The cryoprecipitate technology, the solvent detergent, was CE marked in 2009, and so it was placed first in Egypt. And clinical trials were also performed by the same medical devices in Indonesia. And we were able together to start a place for, I mean, we have one in Egypt, one mini pool plasma fractionation center. And in Jakarta, Red Cross, there is also another mini pool plasma fractionation. Yet, due to the new regulations of the medical device in Europe, the MDR, the company is now CE marking these devices, and they give us a lead time of about 6 months to be able to start to place them on the market once more. In the meantime, now in Egypt, I will tell you, after the mass treatment of hepatitis C, Egypt now has a huge surplus of the plasma. And that's why the National Blood Transfusion Service required from the Egyptian Drug Authority to allow for placement of this technology as a non-conforming product, meaning product that conforms with all the safety and efficacy standards, but still did not get the CE mark because they have a lot of plasma and they don't want to waste this plasma. And we are now discussing the establishment of a center that will be able to process about 100,000 blood plasma units per year. Now, whether this technology can be placed in the national centers or in large hospitals, we would recommend to be in regional blood centers, because it needs a certain setup. It needs access controlled rooms. It needs GMP that the company requires. It needs dedicated staff that will be trained by the company and certified. And it needs a robust quality control lab. And you know, the quality control cost of the factor concern, I mean, the different clotting factors and the immunoglobulins is not a cheap thing. So if you do it at a small scale, it will not work. But if you do it for a region or on the national level, it will fly easily. The other thing that I would like to say that despite Egypt now has a very progressive project for plasma fractionation with graphols and is advancing very fast, but still they are implementing this technology to use the recovered plasma, which at this time will not be qualified for the large fractionation industry. So meaning there is no competition between the two projects. It's always a complementary approach.
Thank you so much, Dr. Magdy. Dr. General Saleem, please provide us your comments.
Thank you very much, Dr. Magdy, for your very elaborate talk and very interesting talk regarding mini pool fractionation as an option for the developing countries. And I think this could be a very cost-effective mean for for using our plasma, which is available with us. I would still invite Dr. Hassan, Zaheer, and Dr. Nuzhat, having their experience in establishing the blood banks and regional centers. Have we ever explored this possibility in our setups of establishing a mini pool at the government level or the private sector? Dr. Hassan, please, and then Dr. Nuzhat.
Yes, thank you very much, Jan Saleem. I think this was a brilliant session with the excellent presentations from all the four speakers. Regarding your question about fractionation, there was one or two private sector partners in the country, basically from the pharmaceutical sector and also from the medical equipment marketing distribution sector. And these two partners were interested in, one of them in contract fractionation and the other one in actually establishing a manufacturing plant in Pakistan in collaboration with some international partners. I think the second one is still, there's hope for the second one, and they're making some progress. I hope we will have some developments in the course of the year. But Pakistan definitely needs this facility because we also have a lot of excess plasma and a lot of plasma which can be potentially generated is not being generated at the moment.
Dr. Nuzhat, I just know you are working on this fractionation project. Have you ever explored this mini pool option?
I think
no,
Dr.
no.
Nuzhat is not here.
Okay.
I would like to actually comment on Dr. Magdy. Dr. Magdy, first of all, thank you very much. You, in fact, had sent a team to us in FIT actually in 2015, if you remember. And that team actually showed us how to prepare the ST cryoprecipitate.
Yeah.
So we are especially very grateful to you. And the only thing which I want to add is that perhaps if we go for like ST treated plasma, for example, so it's not much of advantage in some of our centers. For example, we already do the NAT testing. So if we just pool those cryoprecipitates, so that would perhaps be equal to that of the ST treatment of the plasma. But we would definitely be very much interested actually in the immunoglobulins, which you have just narrated now, that with the caprylic acid and like that. So just wanted to ask you that two things. First is that for example, you said that there has to be a setup in the blood transfusion centers in order to implement that. And then what is roughly the cost of the system? And secondly, if, for example, on a large scale, if we want to go for like our own immunoglobulins, so is it possible for you like to have a setup over here? We can generate our own immunoglobulins for our own clinical use.
Thank you very much for the questions. First, I would like to emphasize a few points about this technology. So actually, this technology does not only concentrate on the viral safety, but also it emphasizes the global safety of the product. So whether the solvent, detergent, cryo, or the plasma fractionation or the mini pool IVIG, they contain steps that will largely purify the product and mix it very close to the industrial product. So it will have a universal use, not restricted by blood grouping. It will not initiate any adverse events. It does not need any prophylactic steroids or anti-allergics, you will use it exactly like the other pharmaceutical products. So this is a great advantage, and we have tested this over in Egypt over thousands of hemophilics in every indication. I mean, prophylaxis, treatment of bleeds, surgical prophylaxis, immune tolerance, and in all it worked and behaved like the industrial or pharmaceutical products. Likewise, it is for the IVIG. So it's not only a viral inactivation step, no, it's a process for actual fractionation. And these devices have been tailored to miniature the fractionation industry, including the filtration systems, which has the capacity to remove cells, cell debris, purify the system, clears the system of the cryo or the IVIG from any pyrogen or allergen, and so make it a very mild product to the patients. And the studies show this clearly. So this is one thing. For the other thing, we studied, I cannot give precise, but according to our studies in Egypt, the cost of production of 1 unit of factor VIII using this SD cryo medical device is close to 8 cents per unit. So meaning if you multiply 4,000 units by the 8 cents, you will the cost will be around to inactivate or to process about 35 units of cryo will cost close to $300, $320. For the IVIG, the cost of 1 gram, I think, is close to about $35. So also much cheaper than the industrial product. So these two things can, I'm not sure, these were our calculations in Egypt. It will depend of course on the company when they finalize their CE marking very soon. But generally, as I showed from the studies, that the using these devices only for the cryo as a source of factor VIII in Egypt saved the country about $3 million by producing 36 million units of factor VIII, which is a significant saving. In addition, of course, to improving the utilization of the waste plasma.
Thank you so much, Dr.
IVIG
Magdy.
Yeah, sorry.
Yes, please continue. Please continue.
I mean, also IVIG medical device is very interesting because if you do not have a properly qualified plasma for the cryo, which needs very stringent GMP to have a good yield of the factor VIII, you can use the 24 hours plasma, the cryo supernatant plasma for production of IVIG, which requires much less stringent quality regarding the cold chain, the situation of the centrifugation, the thawing of the cryo. I mean, there are a lot of GMP steps that we work with you to establish in the center. And so if you, for example, you would like to serve as a service center for surplus plasma in other hospitals to produce the IVIG, the requirements are much less stringent compared to when processing the cryo.
Thank you so much.
Shabneez, may I comment something?
Yes, please. Yes, please go ahead.
Hello, Dr. Magdy.
Hello.
Why you are in darkness?
Hello.
Dr. Saba, switch on your light. We can't see you.
Sorry.
Please. No worries.
This is
no
better.
worries.
Yes. This is better.
Now we can see you.
I forgot. I was sitting there at the before it was sun and looking at the laptop. It didn't occur to me it's in darkness. I just wanted to add quickly. I had visited Dr. Magdy's facility a couple of years ago. Hello, Dr. Magdy.
Hello, Dr. Saba.
Along with our CFO, specifically, I took our Chief Financial Officer.
Yes.
And the good thing is, I've put in, after visiting there, when I restructured our new facility, which is going to be, inshallah, handed over. They told me yesterday in June, which will be a 14,000 square feet facility. We have put in a clean lab with which is at the same standards as what FDA requires, and with all the requirements that we saw in your place. And I'm hoping that once we get in, I've also put in our budgets, a couple of dedicated staff, which Dr. Bari our CEO has already approved for next financial year. So let's see, we may be able to do something and replicate, specifically like Dr. Farhat Bhatti said, 330, we already are giving all our cryo because it's a NAT. We are basically now producing almost everything in our quadruple bags, and we are giving in donation to the Hemophilia Society in Karachi. It's about 40 million rupees a year, sort of a donation. So spending another $300 over it would, I think, not be financially viable. But for immunoglobulins, that indeed, I agree with, in our circumstances in Pakistan, because there is a big dilemma for immunoglobulins, especially for immunodeficient children. And we already have an immunologist in the lab, and she's doing her clinics, and she keeps on sitting and talking about how many IVIGs while she requires. That we would be interested in. So General Saleem, maybe in the next year or so, I'm hoping in the next financial year we start some experimental work, because that lab will be ready. So I'm really excited about that, to be able to do something, inshallah, about it. My last question to Dr. Magdy was, when I visited, you said that company was working on making this IVIG available at room temperature. Has it been successful to store it at room temperature, or is it still in the freezing or in the refrigerated temperatures?
For the IVIG, we prefer to still in the freezing temperature, -20 or colder. But it's very stable product. So we assayed this like we did a shelf life study. It is stable up to 3 years without change. You just keep it in the freezing. But if it is thawed in its way to the patient, it's much less sensitive for deterioration compared to factor 8.
Right. Thank you so much. Now I would like to invite Dr. Saleem for his concluding remarks, please, because we are concluding the session.
Thank you very much for your excellent moderation. And
thank you. Thank you. I'm happy.
And we are really grateful for Dr. Bhatti for sparing his time and very enlightened talk. And I think Dr. Farhat and Dr. Saba and everything, and so many experts in hematology, we can all find the potential of mini pool fractionation in our own setup for the benefit of people. And most of the other talks were related to our own setups about quality control, about hemovigilance, about safety of blood products. They are all interrelated. And Dr. Hassan has contributed a lot in our blood transfusion development, we all know. And this is a journey, rather it's a little slow journey, but still we are hoping that within this hospital coming into it, and Dr. Saba with his continuous hard work and hammering everybody would certainly raise our standards. But regarding the accreditation process, it's not necessary that we can always go to the highest one. We can start with our local standards, and then we can go to the international standards, considering our own cost, how much we can pay for that. And certainly, this needs a change of culture and change of our human resource, how we develop into it. But certainly, we are progressing, and hopefully, the blood transfusion services, which is still quite lagging behind in the developed world, we need to work all together. And I thank all the participants and all the panelists and the moderator itself for having a wonderful session with us. Thank you very much.
Thank you
Thank
so
you.
much. Thank you so much, General Saleem. Thank you so much, Dr. Magdy, and the rest of the panelists and the speakers. It was a very enlightening session. And I hope people like me and Dr. Uzma, who are the RBC people, will have this technology in the years ahead. And maybe, Dr. Hassan, you can come back to Save Blood Transfusion again and do something at the level of, at the national level for us also, so that we can come back in picture, no? Thank you so much. Thank you so much. And now I'll just conclude the session. Thank you so much. Thank you. Thank you, Dr. Max.
Thank you very much.
Bye
Thank you,
bye.
Dr. Farhat. Thank you.